Hi, everybody. I'm Ira Kirschbaum. I am the editor-in-chief of the Journal for Orthopedic Experience and Innovation. Tonight, we have an amazing session on bioaugmentation of multiple orthopedic sites. That's my summary of it. That's not the official name. Tonight, we have a guest moderator, Anand Murthi. I just want to make one comment. If you have comments and you would like to say something or have a comment or a question, please put them in the chat and we will call on you and you will ask your question to the panel, which Anand will be introducing just shortly. So Dr. Murthy, please take it over.
Great. Thanks, Ira. I appreciate the opportunity for all of us to do this webinar. This is an awesome platform that we've been on, I think a bunch of us. I'm Anand Murthi from Star, Chief of Shoulder and Elbow. I'll introduce our panel. Caroline Chebli, longtime friend, is dual trained in shoulder and elbow surgery and tumor surgery. Nirav Amin, sports shoulder surgeon from California. I learn from him every time I talk to him about all this biologics and all the craze. Dave Camarata, hip and knee specialist, and Chris Treat, upper extremity specialist. And so what I'm going to do, I want everyone to think of questions who are in the audience today. There's a lot of smart people out there. I'm going to give a little blurb from our sponsor, Zimmer Biomet, about Tapestry, Embodied Tapestry, and then we'll go and we'll start some discussion. So I'm going to share. Everyone see that okay?
Yep.
All right. So just a little bit about Tapestry, which is I've experienced with all grafts. So this is an interesting one and one I've been utilizing lately for the right indication. Highly aligned, highly porous structure with consistent microarchitecture. It's really, I'm going to try to make it simple because all these grafts are different. It really can create native tendon and gradually resorbs over time, leaving this new or neotendon-like tissue. It's bioengineered. Its microarchitecture is a collagen, type 1 collagen. It's really aligned fibers. What we want, obviously, is to get tendons or in any area of the body to align and heal in the direction of healing along their Sharpie's fibers. And it's off the shelf, stored at room temperature. And I think that highly organized collagen is one of the important things. So what I look for when I'm looking for an implant is, off the shelf, easy, inert. We're not looking for reactive properties that cause these kind of these bad effects. Biointegrative for healing. We want tendon-like tissue and that it goes away over time. So we want angiogenesis. Anything that heals, we need blood. We need blood supply. We want tenocytes. We're shoulder surgeons, a couple of us on here. We're looking for tenocytes and cuff healing and support cell growth along the way. This is just kind of a slide that shows the microarchitecture as we get the cell migration to stay incorporate into the tissue, the poor tissue we want to heal with that high porosity and then get these tendons to heal over time. So this is a great kind of just a visual slide to look at the differences in some of our competitors between Tapestry, Regeniten, and kind of dermal matrices type of tendon repair and structure, what it looks like. We always like to throw these fancy micro spec big words. For me, it just looks like it's lined up well. I'm a simple guy. So this is the sizes that come in. We're going to be focusing on kind of open situations or open cases today, and this is where it's been used the majority of times in all the different parts of the body in orthopedics to get these difficult places to heal. So that being said, I'm going to stop sharing for now. I can.
You did.
All right, cool. So we're going to start some questions off the top of the bat. So I'm going to start with Nirav. Nirav, just let's start us off the bat with, when do you think about using grafts or augmentation? And I'm going to kind of go around and ask everyone, since we're all kind of different specialists here.
Yeah, I think Anand, for me, twofold. I think in my shoulder, I would say in my sports practice, it's more at tendons, which I find at risk. And when I think at risk, I think of smokers, diabetes, or revision type settings, or chronicity of the tendon tear. When I think of my arthroplasty side, doing knee revisions, I think the ideal setting is if I'm doing a knee revision and I'm creating exposure to explant the tibial base plate, and I start to see the medial 1/3 of the tibial tubercle peel off a little bit, I normally will pin the patellar tendon. And if I see that start to peel off a little bit more, I do worry about the interaction between the tendon bone interface on the patellar tendon, and I will augment it in that setting. I'm not sure if I believe it should be utilized in every single revision total knee I do, which I don't utilize it in, but I think there are indications and scenarios, especially in the setting of our implants, showing longevity and survivorship of 90% up north, that it seems like biology seems to be the kind of missing grail. And you and I have spoken about it at length. And I think now we're on the next horizon of biology being that area. So I think I would call them at-risk patients would be my ideal candidate in that setting.
Awesome. Caroline, you're seeing some tough cases with tumors and revisions. I know the patients you operate on. What cases are you looking to use some type of augmentation for, and why?
So I think the majority of the time when I use it, I started, I mean, I guess the basis is that if you look at healing of, the subscapularis, no matter what type of how you get into the shoulder, whether it's a peel or a tenotomy or even an LTO, I think George Oswald did say they show that like 70% of those heal. And so in my mind, I'm like, well, that's a lot of people out there that are not healing their subscap. And so I started using it pretty much on every single guide to a peel. So when I repair my subscap, I will use it on that like routinely, because I think that 30% is a pretty high number to not heal on it, even though we don't see like the downstream effects of that within like the 2 and 5 year studies. I think at some point we do. And then beyond that, I will use it on, my chronic tear. So if I have, like I did a triceps that was chronic, or, if I'm doing any of my tumor cases and I'm doing, you're doing like an APC, or you're asking something that's dead to heal to something that's live, I'll use it to augment. So, I mean, I have a lot of, I use it quite a bit actually.
That's perfect. I'm going to segue into a case here. So, and I didn't even set you up for that. So this is what, can you guys see this? Caroline, can you see this?
Yeah, I can see.
So this is, I agree with you. We're trying to, whatever we do in orthopedic, especially in shoulder, we're trying to get to that higher and higher percentage of a good outcome, and 80 is great, 90 is great, but I want to get to 95 or 100. And so same with you. If I do a tenotomy, or if I'm doing anything where I want tendon to tendon, or even tendon to bone, I like to utilize this. This is a right shoulder post tenotomy repair. So I've reinforced it with a Tapestry graft. You can see the alignment is the blue lines. And you can see, I'm a simple guy. It really, when you put it on, and so I use monocryl to sew it in. I actually used active braid here as well, which is a biologic suture. And you can see the wicking properties of the blood. I mean, it just essentially holds it there, brings the cells there, brings your colony forming units there to help it heal. So that makes sense to me. There was a study, Amit Mithani with ultrasound showing the subscap tendon intact, utilizing this patch graft. And so that's also in the Joey. Shout out to Joey, which has shown us that as well. So I'm going to close that off. Let's go back to stop share. All right. So what do you think? What do you think? I'm going to go to next. Chris, Treat, what do you like to use biologics, and who do you like to use biologics on? But first, let me ask you another question. I didn't even let you answer the first question. If cost was no option, would you use patches and grafts more?
Or was that to me? Yeah.
Yeah,
if there's no option, would I use patches and grafts more? Well, it's really not an option for me because I'm kind of hospital employed. So,
so am I. That's why I said if there was no option.
It's a loaded. Yeah. Yeah. So I would say, thinking, if you had asked me a year ago, I agree with the first doc here that the high risk patients, diabetic smokers, revision, and especially in hand surgery, revision tendons, chronic tendon injuries. But to be honestly, I have kind of evolved into using it almost in all of my hand tendon cases, mainly because of, for me, I think kind of a key factor in repairs, especially in hand and tendon issues, is it comes down to tissue quality. And so I think being able to augment it, I think it helps a lot. So I would say originally high risk diabetics, smokers, that classic, that's a good subset of patients, but honestly, it's kind of evolved into almost every tendon case in hand surgery for me. And then in shoulders, I use it in my biceps tenodesis. I use it at intermuscular junction. I think there's a high risk of failure at that place. So
No, where were you?
I will do it there too. Can you learn from?
Good answer.
Yeah.
There's a young child who wants to contribute.
Yeah.
We get them young. We're getting them young. I thought the patient at risk,
You can't.
can everyone mute who's not speaking? Thanks, appreciate it. About these patients at risk, and for me, cost is an issue, so we try to use it for people who have, for cuff, high Rohe scores, smokers, age, diabetics, large tear size, poor quality tissue. But I'm thinking more and more as I age, if I have a guy or a gal who's in their 50s, do I want to even risk that small percent that they don't heal?
Yeah.
If I have something that is readily available, easy to use, something to augment that has low. I also always look for a complication profile. What are the potential complications of use? So
yeah,
it sounds like
I think for me, we all want good outcomes, and we're all here. We're learning tonight, trying to figure out how can we make better outcomes. I think when we put our name on the chart, we take them back to the operating room. The goal is to not come back. And I think in hand surgery, particularly with tendons, it can be a devastating blow to come back. And so, in my opinion, I think augmenting and doing what you can to do it right and get it perfect the first time can really save you in your practice, especially on your patients. So in Oklahoma, you don't have a lot of wiggle room to have complications, at least where I live. And, we all know each other and we're kind of at the same football game. So you want to try to get the best of the best. So, yeah, I've been real happy with it.
Excellent. Once again, if people have any questions, please put them in the chat and we can get to that. Is Dave online? Dave Camarada? Is he with us today? If not, Nirav, do you want to show your biceps case? Are you good for that?
Yeah, ready. Give me 1 sec.
So Nirav is going to show a case of a distal biceps that he utilizes a patch for, patch augmentation. And I think more and more, at least tissues, there's a reason that tissues tore in the first place. So, augmentation, I think, is something we'll likely see more and more utilized. And once we get better and better outcomes and results, we'll get more and more insurances authorizing it too, I think. Take it away.
Yeah, so Anand, this is a chronic distal biceps. So this is 6 months out they came to me. I typically start with, you could see my incision. I use fluoro. I'll tell you a quick story. So I had a story. I wasn't using fluoro before my distal biceps. I just go 2 finger breaths from the flexion crease down. Yeah. And I heard of a story of a surgeon essentially putting the screw into the radial head into the tuberosity. And ever since that day, I use fluoro on every single case for distal biceps. But essentially, you can see the distal biceps here. It's about 6 months out. I was lucky enough to actually get the tendon to come out singularly and release the adhesions around. What I do is I use a little suture. You could see I whip the suture, and you could see the end of the distal biceps, and you could actually see kind of the flared episode of it, or the chronicity and nature or so forth of that tendon. So essentially what I did is I cleaned the edges up with a fresh bleeding edge. The rationale I used on this patient is because it was chronic in nature, I was worried about the enthesis and the growth going into the actual footprint coming in. The reason I find this a little bit engaging is on this aspect, you can see me putting the Biologic patch on, and you can see on the bottom right of the Biologic patch, you can actually see the porosity of the actual implant causing actual vascularity coming in literally seconds after you laying it on. And then if you notice on my next image here, you can see me suturing it on. And by the time I kind of come in on the bottom right image, you can actually see by the time I'm done suturing it, I use the same thing you do on, and I use a 3.0 monocryl to stabilize the implant to the tendon itself. And you can see it's actually already vascularized at time 0. So
Yeah.
for me, that's super helpful because at least in my mind, I think to myself, I'm adding biology and it's actually incorporating it in and it's already showing that. And here's just my C-arm images, right? So you could see my pin coming through bicortical. I flip a button. I like doing it this method. I feel it's a lot safer. I feel like I know my button's reduced. And then lastly, I just kind of use this my adjustable loop, zip loop, and I loop it down. And I find this to be, at least in my hands, the most reproducible in this setting to do my distal biceps. So I think in this setting, if you ask me if it's an acute distal biceps that's came to my office like 1 week ago, that's not a wrist, a healthy guy, I may not be as apt, but I think in these settings where there's a risk, and I think what you said and asked the $1 million question, if cost wasn't a parameter, would I be using these biologic augments more? I think the rationale reason is yes, unless I see an adverse reaction taking place. But I think in the reality, we have to live in the segment of, are we being cost conscious as surgeons and clinically offering patients the best clinical utility? And I think that's the tough part, challenging it, because we're going through the literature as we move forward.
That's awesome. While I bring up some more cases, we have a couple really good questions in the chat. I'm going to go with the first question. Maybe we'll ask Caroline. What has drawn you to Tapestry for augment versus all of the other current collagen and implants on the market? And I'm going to pull up some stuff while you give me a great, awesome answer.
Okay. So I have used a bunch of different other ones. And so actually I have the advantage. So one of the guys who was responsible for inventing it, Michael Francis, works at USF now. And so I got like a little tutorial on it, and he explained to me the whole process, and so it was actually like very enlightening, like how he developed it, why it is better. And so, after having had like that little tutorial on him, that I was approached by Zimmer with, hey, would you try this? And I did. And I really like that. I really like the concept of it. I like the fact that the collagen fibers are all in line, that it like mimics tendon, and what I have noticed, I mean, this is probably anecdotal, is that I am actually doing a study looking at tendon healing on these patients, and clinically, and I'm going to look on ultrasound, it seems to heal pretty well. And so like their subscap, in terms of like, I feel like they do heal, like they've good subscap strength, like 3 to 6 months out.
Awesome.
So I just having had that like little tutorial from Michael Francis really sold me on it.
Chris, why are you using Tapestry versus some of the other ones?
Yeah, well, I think in hand surgery, it's not.
You have certain indications to use it versus another.
Yeah. So I think I've only used the other one as Regeniten. I think the thing I like about it in hand surgery is that it handles really well, and especially in small areas, it's got a good mold to the tendon. It's got that circumferential fit that you want. I think that's important. Post-operatively, it's not as bulky. And I think those are kind of the keys for me. I think there is a little bit anecdotally less scar with it, but probably most important would just be the handling of it intraoperatively and being able to get it around the tendon there.
Excellent. We had a question on the chat group of the utilization of Tapestry and hip and knee replacement. I think maybe Nirav can comment on utilizing it for at least for knees. This is a case, if everyone can see up here, Dr. Whitney did, he went in to do a patella resurfacing after the initial total knee, and he had used Tapestry for capsular closure. And this is kind of an open second look, going in for the second time to resurface the patella, and showed this capsule essentially was watertight and back to essentially pristine. Nirav, what do you think?
Yeah, thanks, Anand. Dr. Wickline, great question. I think the role in total joints, I think, is twofold. If you look at the Yellow Journal article that just came out, I think about 18 months ago or 2 years ago, talking about us using a unilateral barb suture and the complications associated with that. I think there's a role, at least in my setting, of the tissue when you're doing the arthrotomy and you're closing the arthrotomy. And I know surgeons vary on closing in flexion, extension, and I think there's variability in that setting. But I think if you have extremely tight closure, for me, after I close my arthrotomy, I'll flex and extend the knee. And if I see those sutures under a lot of tension or load, or I see them unloading, especially at the inferior pole of the patella, at that point, I think it's reasonable to put some kind of biologic augment in Tapestry. To me, seems like the viable answer just because of the thickness of it. It allows it to incorporate in. It doesn't add any thickness in that level. And the importance to that is twofold. Number one, that skin's very at risk in that area because it's hard to close that arthrotomy site. And number two, if you're worried, especially in a revision type setting where you've peeled off the medial 1/3 of the patellar tendon, my concern is if that's coming off and now they're, let's say, a smoker, a rheumatoid arthritic patient you're doing a revision on, this may at least give you a little more cushion or a little more comfort in that area. So I think the cost parameters, I think you would probably have to ask. I think your next question was, what is the cost? I think it's market driven, honestly. I think you probably have to I'll refer you back to ZB and Nature. But I would tell you on the setting of being an implant-based product, there are codes that are available to navigate around the parameters. And then I think the next question, that $1 million question that gets asked for all these biologics is, well, how do you do this in an ASC? Is it cost prohibitive? Is it cost conscious? And I think that all depends on your contracting of your ASC. And then if it is, say, something where a patient doesn't have benefits, do you offer this to patient and then have them sign an ABN and then an explanation of waiver benefits? Those are all kind of platforms that we can kind of go into on the cost parameter. But I think the real patients that you can use it to in joints is the patients at risk, especially in the revision setting. And I think the primary setting has a role too.
All right, Juliana wanted me to show the stamping video. So let's watch
patch and no patch. This was a clean soft tissue plane, and here there's a little bit of this adhesive scar.
All right. Thanks, Nirav, for that awesome answer. I am going to let Nirav load up the case while we talk a little bit about some more cases. So I'm going to pull this up. I'm going to go to some of Chris's stuff. Here we go. So Chris, talk to us a little bit how you utilize this in a thing we see and a problem we see all the time, tennis elbow.
Yeah. So I've actually recently been using it, especially for like again, kind of the revisions molded into the primary stuff. But I repair it as normal. I do kind of the condyle, go down, split it up, and then repair it. But what I've been doing is placing the Tapestry patch over the top of it, and you can see it kind of nice mold down into it, and then suturing that in with a monocryl suture. Then we let the tourniquet down and kind of create that environment. So, I like it. It kind of covers the knot stacks. You can put that anywhere. The ones I've seen post-operatively, anecdotally, haven't seen any issues with drainage or any bulkiness at the site. And I think it's adding that extra augmentation that's needed. So, I've been happy with that so far.
People ask a lot about, especially in this cuff, about reactions, rice bodies. I know some of the other products have had some reactions. Have you seen, obviously, extensor? I can imagine extensor tendons. You don't want to have any kind of reaction there. Have you seen reactions with the graft at all?
And no, I haven't. I've seen a couple with the regenitins arthroscopically, but I haven't seen any. But I haven't had a whole lot of second looks. But no, I haven't had any in the time that I've been using it, or appreciate anything like that.
Awesome. This is a case Dr. Chebli forwarded on, and I'm a big proponent of lower trapezius tendon transfer for irreparable cuff, irreparable posterior cuff. And this is the junction site. Caroline, you want to take us through what you did here?
Yeah, so I mean, right after I attached, I did like a pulver tap and weave and sewed the Achilles allograft into the lower trap transfer, and then I just kind of wrapped it around, and it, like, as soon as you put it on, it just kind of like sucks right down. I mean, And I just use like some monocryl, like you said, like 3O monocryl is what I'll use, and just kind of tack it on the four corners. But honestly, I'm like half the time I'm like tend to like not to even do it, because literally as soon as you light it down, the blood just soaks in and it's just like on
Oh,
there.
you mean not sew it in because it just
Not sew it
seeps.
in. I mean, it's like it really just sticks down so nicely. So
This is a right shoulder. The Achilles is to the right. The lower trap is to the left, and you can see how nicely it fits in. This is one of my patients I used to graft on 6 months out from her lower trap, and we had done one of the reasons I've started using this for that site is when we published our MRI series. We did have 2 out of the 21 that didn't have healing at the pulvar tap site between the lower trap and the Achilles. And like I said, I'm trying to maximize. And that's, anytime you're using allograft and you want it to heal to native tissue, I think that's another site. We're utilizing the Tapestry graft or a wicking type of graft that kind of aligns your cells is a good place to do it. So that's where I'm also using it as well. Do you like to use it on your primary cuffs ever, Caroline, or just revision?
For my subscap repair, I use it on my primaries. So for my open surgery, I use it on all my primaries now. So I'm not limited by monetary issues. So awesome. I'm lucky in that way.
I am going to ask Dr. Saglioni if he's on there. I hope I'm pronouncing that right. What indications and where you're using the graft now too.
Hi, Anand. Great panel and great cases. Appreciate it. Enjoy it. I appreciate the question. Yeah, the way I see this is, and I think some of the points made are excellent, is that, my indications are also in shoulder arthroplasty. And at this point in my practice, in my position, I end up, I don't know the number, but it probably is less than I'm thinking in my mind. But about 30% of my cases are revision cases that get referred into our department here in New York. And so the revision cases are, as stated, probably the best indication with tissue attenuation. I would agree with all the other comments about protoplasm or greater than a Rohe 7 on my cuffs. One thing I would add in terms of indications is on my multi-legs for the extra-articular portion, posterolateral corner, posteromedial reconstruction, where I'm using allograft. Again, extra-articularly, I'm adding that. I think the key for everybody to think about in terms of when you look at patches is obviously you heard a little bit about the uniqueness of the architecture, but you also have to think about the mechanism of action. So is this a structural graft implant? No. In my mind, it's a biologic. It's chemotactic. You want it there and you want it then to go away. So when you look at patches, you want to understand degradation kinetics. You want to understand, is it there for the healing points that are most crucial, and then avoiding stress shielding. And so that's how I differentiate it. I think others on the panel brought up adverse events, both rice bodies, but also inflammatory reactions where you see exuberant inflammation. You don't want that. I've seen that with other patches, and that's made me, I think, shy away from that. And then cost. There's a great study that was published in Arthroscopic by Lou McIntyre on the cost of failure of rotator cuff surgery. And he did this beautiful cost analysis on using a patch to perhaps reduce failure in rotator cuff surgery, which is not only a crowd pleaser, but I think in the long run saves all of us a lot of money. So I think you need to think big.
Yeah, that's the hardest thing to prove to insurance companies is the cost of failure. They don't want to hear about the cost of failure. They're working on time zero, unfortunately. Thanks, Nick. I wanted to ask Dr. Nathani's on here. Can you tell us a little bit about your experience with the subscap repair and what you published in Joey?
Yeah, thanks. This is great to see all the diverse clinical examples. That study we published about a year and a half ago, and it was only a 5-patient clinical series, so it was really a safety and efficacy study. And now we have a multi-center, multi-surgeon study going on, and we're about a little over a third clinically enrolled. So we'll have, increased numbers and increased power in that study to show subscap healing. I think the best way, that I think about it is, subscap failure really mimics what we know about our arthroscopic rotator cuff, healing rates. And we're starting to learn more and more as we can stratify these patients, what our healing rates are, and depending on what you read, it can be 20%, it can be 80%, but identifying those at-risk patients, as Dr. Amin also said. I think the same is true when you take the subscap down during a shoulder arthroplasty, and we know it's critical to outcomes to get it to heal in anatomics. And I would submit to this group that there's recent data saying that it's probably important to get it to heal even in reverse shoulder replacements, especially if you look at internal rotation strength and getting people that functional internal rotation after a reverse shoulder arthroplasty. So if it helps in anatomics and it helps in reverses, and we know our failure rates are high, and we know that that cuff isn't always normal in an arthropathy type patient, it makes sense for me. And then from a cost value standpoint, Dr. Murthy, I think the cost of failure in an arthroplasty setting is, factors higher than in the arthroscopic. So obviously that's sort of where it's fit into my practice. Every primary anatomic and every primary reverse where there's a repairable subscap, and then certainly in revision cases.
Awesome. Appreciate it. And, my worry always about using any kind of graft on an arthroplasty, right, is infection or reaction or something untoward that's going to happen. But it's good to see that there is no real reaction, or we're seeing any kind of untoward outcome utilizing these grafts from you and Dr. Chebli, and I've started to use them more. I think I need to do more totals now too. Maybe it'll switch me to doing more totals versus reverse. Oh, we have a young surgeon online. I see her. So what I'm going to do now is I'm going to get Nirav back on to show us a little video about, we are focusing a lot on open procedures. We're going to do a little scope talk, scope a rope, scope it open, show us how we use it in the cuff. He's a slick surgeon, so I know I've learned how to use this from him. Nirav, you ready? You loaded up?
Yeah, give me 1 second, Anand.
Sure. And then I think Dr. Ian Whitney's on now. We'll probably bump it back to him to talk about a little use in total knee replacement as well after we're done with this.
So I'll just give you a quick clinical vignette of what this is. This is a partial cuff tear. I treated this patient non-op for 6 months. They tried physical therapy. I normally will have my patient go to therapy for at least 24 documented sessions. And the patient failed, continued to have clinical pain and discomfort. So this is the arthroscopic version, non-edited. I will tell you, I'm in a beach chair position. The tech is on my right. I'm viewing from the posterior portal. The stapler, which is in the beginning of this video, is coming in from a lateral portal, and my implant will be coming from the anterior portal, just to give everyone an orientation of where we are in the shoulder. So I think it's important to understand when you're doing these biologic patches to understand kind of real utility and viability. I think because sometimes people are like, hey, look, we can put these in like 10 seconds and 30 seconds. I think here's a real unedited view. So you can see my tech handing me the implant in. Anand and I have some great stories on our early utilization of kind of getting through this process, but it's really kind of getting better and better and streamlined in our hands. So what happens is we come in from the anterior portal. You can see my tech handing me the implant. Just so you know, the tech right now is kind of holding on. I'm holding the camera with my left hand and the stapler with my right hand. Once I like where it is, I think if you're early in this process, you want the tactile feel very important to yourself, unless you trust the tech. My tech here is excellent. I've been working with him for 3 years. He understands the tactile feel, but if you're not comfortable with your tech and or resident or fellow, I would highly recommend that you do the malleting and the stapling yourself. You can see one of the advantages right there, because it's a dual stapler, you actually don't have to take it in and out of the shoulder. You can actually put the first stapler in laterally, click a little button, and then slide over, and then you can see the tech malleting in my second staple. Once that happens, one of the key aspects that will happen here is once the inserter is in, you'll see me actually take the entire inserter off. The key part here is the entire black handle must come all the way to the back before you do anything here. And then once you do that, the second stapler will come in. And essentially, once the second stapler kind of comes in, what I like to do again with this is you'll come in from the lateral side. There's no accessory. Just so you know, once you pull the staples out, you see my tech kind of coming in, my medial side comes in. I'll lift that off, I'll click over, and then I'll come on the anterior medial aspect. I'll put my tongs back out. I'll have the edge of the graft, and you could see there's no editing in the video taking place and the implant's in, right? So I think once we get used to this process, you could see once the water goes away, this implant's really flush. So I thought it would just be helpful for those who honestly, like a lot of times, Anand, you and I both agree, you'll talk about putting these implants in, you'll be in lectures and so forth, and they'll show you these videos and they're beautifully done in like 30 seconds. And what you don't know in the back table is everything misfiring and so forth. But I think once you get used to this process, for anyone who's used this in a setting, it can be reproducible and really efficacious to your patients in that setting.
That was great. I'm glad you got to show us on a cadaver. But no, that was great. I mean, it is I think when you realize that you need to have kind of time zero fixation, and then you turn the water off, you'll see the wicking occur like in a second, just like you do open. And then if you move the shoulder around, it really is the word is plaster. I use it with our fellow. It just gets plastered on to the cuff and the cuff bone junction. So that was a great video. Is Dr. Whitney on? Dr. Whitney, calling Dr. Whitney. Maybe not. I was told he was on, but all right, that's okay. I'm going to call on Professor Redler. I see you there. Michael, talk to me about your usage of grafts now, when you're using grafts. Welcome to this. Welcome to the webinar, my friend.
So Anand, great to see you. And just to let you know, I watched Anand and Caroline do a lower trapezius transfer with no allografts available in Honduras, and give great outcome or potential outcome for a patient where we have less to work with. And so these are still two outstanding surgeons, and I admired what they were able to do. I think the use of the ROHI or ROHI index is really important. I think part of it is also the gestalt especially for rotator cuffs, of where you need to have augmentation. It's always been my theory that if you're going to augment, you'd like to have strength plus biology, which has led me to use a product different than what you're discussing, which is BioBrace. I think that the partial rotator cuff tears are a different story there, where we're looking for more biology. And there, I think we're looking for more simplicity of implant, and plus the biology. I think there's a lot of products that do get wicking. I think that the regenerative product tends to be one that it's kind of like operating on wet toilet paper, so you need to be very careful with that as well. But I think those are two different pathologies in my case. I think that when you have to have something, and Chris, you talked about in hand surgery, with tendons, you need something that's pliable, wrap around. There you want something that's more just biology there as well. So I think there are different indications for all of these. I think that some of the indications you've showed tonight have been very impressive. I think that for cuff tears, and especially those high ROHI index cuff tears, I want strength plus biology as well. What do you think about that, Anand?
Yeah, I think using them in different, I wouldn't use this for structural, I would use this on a biologic. So if I'm having an issue with structure, then I'll use some type of structural graft, or if I'm doing an irreparable cuff, and then I'm doing a lower trapezius usually. But definitely for biology, I think if you can get a repair and you're trying to maximize your biology, then you can get it with a biologic type of graft. And here we have alignment, which I think alignment of cells, which kind of gives it a little bit different than some of the other products.
So question for you, for the partial rotator cuff tear, and that was an impressive video. Are those still PDS staples that are being used to fix it?
They are PDO staples.
Yeah, it's a different material, Mike. then
Yeah.
I mean, the question is, because I think that a lot of times you see with Regeniten a significant inflammatory response about 3 months in a lot of patients. A lot of people have attributed this to the PDS staples as opposed to the graft itself. So this is a different construct here.
Mike, I would point out, yeah, I think this is important. At least in my mind and hands, it was important that their PDO, which is polydioxanone, which is PDS. So the inflammatory profile, the degradation profile is very different from some of the other proprietary staples, which may or may not be the cause of those rice bodies. But I do believe in my mind that the safety profile with this implant has been better. And also, I don't like using PEEK in an implant in the bone. So the PDO is used on both the medial and lateral sides, and I think that's an attraction.
I think to me, that's one of the biggest take-home messages, because we all see these partial tears that really need something to be done, but you don't want to cause more problems with inflammatory response. So that may be like one of the big pearls of the evening for me.
I've got Dr. DeFelice online here. Greg, where are you using grafts, augments, about the knee? Talk to us a little bit about that.
Sure, I'd love to. Thanks for handing it over for a couple of comments, and great conversation so far. Most of my work is on primary ligament repair. I have a trauma-heavy sports practice, and so I use the biologics, similar to everyone else, all around with questionable tendon vascularity, etc. But for me, one of the things that I really needed in my practice was I needed a suture form of the collagen. And so a few years back, I was working with Nick and Kevin Bonner, and we came up with active braid with a company called Embody. And the initial attempts were to try and develop a completely collagen suture so that you could get your biology simply from your repair stitches rather than having to lay big patches on. And we ended up coming up with a 50-50 collagen co-braid because we needed more strength. But that product is out now, and the reason I mention it is because Zimmer bought Embody, and Zimmer has brought out Active Braid and is distributing it now. I have been using Active Braid for the past 10 months, which, as I mentioned, is a collagen co-braid. It's half essentially fiber wire and half collagen. And I've been using that for all of my rotator cuff tears, for all of my ligament repairs in the knee. Anytime I have a tendon rupture, either pec, triceps, biceps, Achilles, quad, or patella tendon. And what that allows you to do is to get that biologic augmentation without having to change your technique whatsoever, and without having to add any big patches. You can get that biology and that wicking of the blood. So I do use patches in situations where I've got really sick tendon or in revisions, but just for my basic stuff, I use the Active Braid, and I would encourage you all to have a look at it because it allows you to really kind of augment your repairs without having to go to the bigger and more expensive patches.
Awesome. Yeah, I've had great usage of the Active Braid as well. I'm going to go to a case of Chris's, and I want to see what his commentary. There's a lot of people on here, upper extremity surgeons as well. Let's see if I can get this. Chris, talk to us about how you're utilizing this in your hand surgery and wrist cases as well, and what typical kind of cases you're doing it, and where you're doing them, and how you're utilizing Tapestry.
Yeah, so kind of what we were talking before, originally kind of started out using it for like the complex revision, tendon repairs, chronic tendon insufficiencies, and ruptures. it's kind of into almost everything. I'm a hospital employed, so I really, I'm fortunate not to worry about the cost part. But this is another example of a chronic tendon injury. Use it a graft, pulver taps it in, and then just put that tendon right over the patch over the top of it. You can kind of see here, that's nice. You got a circumferential fit, it's got a good fit. It kind of soaks in or molds around the tendon. And then, post-operatively for me, no one wants to walk around with big old scar. And I say that, and this is a big old open wound here, but, scar tissue, mobility, emotion, and you don't want your graft to adhere to the skin. All those are important. So I think being able to get this good mold and fit on the tendon and also augmenting it with the biology helps a lot, post-operatively for that. But
That's all. I mean, you would think that graft would cause some bulk, so do you feel it?
Yeah. And I wish I could have I actually took another picture right before the foot and ankle surgeon who introduced me to the product about a year ago. He was doing a lot on his Achilles. He was about to give a talk, and I showed him the slide of the patient. We had a movie or a video as well as a picture, and it's actually pretty cool. And you'd think it'd be a lot of bulk, and it's really been surprising. I didn't use anything prior to for that, so it's only been about a year of me using the product. So I think I've been happy with it, and the patients so far, anecdotally have been happy with it. So
it'd be cool to when you have time to get a video of them moving.
Yeah, I should have brought it. It would have been the greatest. Yeah, it would have been good. So totally dropped the ball on that, man. Sorry.
We'll see at some point or an MR. I mean, that's a great case,
Yeah.
Anand, this is a great example, right, of utilization in open platforms where you're worried with very little skin coverage, superficial to any biologic augment, right? So if you look at the biologics on the market, this may lend you credence to, let's say you're trying to put the Achilles biologic augment on the superficial aspect or closest to the skin. You're truly concerned in that setting. Like when I do my Achilles, I use a parse technique, right? I have a small incision. But the biggest concern we all have is the wound dehiscence in that area, poor vascular flow and so forth. But you could see if you wrap this around, I call it like a burrito type style. And as Caroline was saying, a lot of times you're almost tempted not to put a suture in because it almost like sucks down so quickly. I mean, I think most of us will put a suture in, but you're almost tempted not to. And I think this is a perfect window or an application where you can see when you have very little tissue tendon interface that you're comfortable using this biologic augment in this space, in this setting.
Yeah, it's really nice. The skin's not adhered to the graft. They're good mobilization, and it looks real nice afterwards. So I agree.
Is this do you remember, Chris, when you dropped the tourniquet, if it got really, did it rip all the blood?
Yeah, kind of like the doc was saying earlier from Tampa, it just soaks in, and you want to try to get it all done before you drop the tourniquet because it almost blends right back in with the tendon, and so it kind of soaked in and molded nicely afterwards.
That's nice. I know a lot of my foot and ankle colleagues, they really like to use it in Achilles, and I guess this is kind of one of the Achilles of the upper extremity. Caroline, can you show us your technique here, or take us through your technique on it seems like we're using it a lot in these chronic cases. I think chronic is great. I think I'm going to push towards doing it in more kind of acute cases as well. Talk us through your technique and how you did this case.
Yeah, so this was a guy who was a 50-year-old guy, and so he had this triceps tear because he had some cardiac issues. We didn't get him to the OR till like 6 weeks. It was like really retracted. I almost had to fix him. I think I fixed him in like just 10 degrees, 20 degrees of flexion. That's how tight it was. So I did a double row repair of the triceps, and I was really worried about him healing. And so I just laid that on and then sewed in the four corners using the monochrome patch and the Tapestry with the monochrome patch. And that was even with like the tourniquet was still up, and the blood even kind of started seeping in right there. And so
yeah, that's what I was gonna ask you. So that's with the tourniquet's still up.
Still up, yeah. Yeah.
And any issues with drainage or swelling or anything like that?
None. I haven't. I mean, you and I remember, like 20 years ago when the first diffuse patch came out, and you have that like horrible reaction, and so
right.
to it. You don't see that with this at all. And so, and I've used it on a, I don't know if I sent you the case where I did a total elbow, where I did a tricep split. And I was like, it was a guy with rheumatoid, and did a tricep split, repaired the tricep split, and then just like laid the patch on over it. And I mean, this guy was like completely, this is him. Like, this is like, I was completely non-compliant. He's like 82 years old. He was like, moving his elbow. He came in like, nothing, like 2 weeks later, moving his elbow, and thank God it worked. So
I think
it just makes me feel a lot better. If there's, just the integrity isn't great or in the chronicity.
We're getting some questions on the chat about what's the harm if it's not sutured in. It seems bulky. I don't think the bulk has been an issue. I think once it wicks up, it begins to really kind of compress and get aligned. So I don't think anyone's noticed anything with like bulk. I mean, if you don't see bulk in an extensor tendon, and Chris is telling us that's pretty.
It's really thin anyway, and it's like, and it's compressible. It's not, like a dermal allograft. I mean,
right.
It like, as soon as it like the blood seeps in, it literally just sucks down, and I mean, it's probably like 0.1 millimeters, not even.
Dr. Bajian, any allergic reactions? I think we haven't seen any, and I don't think the Tapestry people have said there's any reactions. Brian Cook, we see a lot of fish skin being used in a lot of these indications. Has anyone had any experience of that to Tapestry? Panelists, I do like sushi, but I have not seen fish skin. Nirav, Chris,
I have
fish
not,
skin?
Anand, I have not. The allergic reaction thing is really interesting. I think, I had wrote a letter to JSES on the first case report. I know there's anecdotal statements out there about the biologic reactions to these shoulder augments. To my knowledge, there's 2 to date that have been published, right? There's one in JSES and there's one in JBJS to date. I think in one of the studies, the surgeon went back in and did an arthroscopy. In the second study, they did an injection into the subacromial space. So to my knowledge, if you look at the Tapestry literature to date, I believe there are north of 9,000 cases implanted, and there has not been a level of any kind of reaction to date. So I think when people ask, well, what is your concern in that level, or does that let you sleep a little bit easier in that setting? I think when Chris showed that really elegant case with the extensor tendon of the hand, I think it just allows us a little bit to be a little more comfortable in the setting, because there has not been, at least to my knowledge, I think we can ask the panelists across the board, but to my knowledge to date, have not seen any foreign reactions using this implant.
Yeah, I mean, I agree with you, and that's always been my concern. When Carol and I started using the Restore patch way back when she was a resident, I was first in practice, we used to see those reactions all the time, and a lot of them were just some reaction to the product versus an infection, but there was a rush to kind of take the graft out, and that's something you don't want to see. So I'm glad we haven't seen those in these cases using Tapestry. So we have a few minutes left. What I'm going to finish up with is just to kind of give everyone some last words, and then I'll finish it off, and then Ira will finish it off. So Chris, why don't you talk to us about where you think the future of grafts are, where you're going to be using it?
Man, if I knew that question, I wouldn't be here right now. I'd be somewhere in Vegas or something. But no, I think I think augmentation, I think the goal for me has always been kind of, if I can just do the right thing, I'm taking patients back. I want to have good outcomes. I want to be able to go to the OR, if there's ways to augment my current, practice to get good results and good outcomes. I'm always open to that. I think that's kind of the focus. Biologics is huge. I think we need to get on top of it. And I've been fortunate to be part of the hospital setting where I don't have to worry about, the real world part you guys have all been talking about.
Caroline, how about you?
As far as augmenting and repairs and stuff.
I mean, so like I said, I've been using it on all of my totals and my reverses, primary or revision. For my oncology cases, you are really asking this, tendon to heal to tendon, heal, back to a metal implant, in the face of people who are getting radiation and chemotherapy. And I think that this is I mean, incredible adjunct to this. You guys got me thinking about using it for, I cannot stand lateral upper condylitis.
I know.
It makes me want to quit. And so, but I was like, wait, what if we can do, because, you know, I've been using it a ton on my patients who fail, partial rotator cuff tears, and and they've done the injection, they've done the physical therapy, and I've been laying it on, and I'm telling you, they come back in a couple of weeks and they're like, it doesn't hurt that bad, and they seem to rehab well. And so maybe I'll start seeing lateral upper condylitis again and see if there's an actual indication.
I know.
It's not worth it.
Tennis elbow. Nirav, how about you, my friend? Finish this up here.
Yeah, thanks, Anand, again for having me on the panel. I think the reality is I think we're on the early frontier of biologics and shoulder arthroscopy in open setting biologics. I think I parallel this to the recon side of total knee arthroplasty and robotics for total knees and hips. I think there was a lot of apprehension and concern when robotics entered that space. And if we kind of fast forward to 10 years from where I was, even in fellowship, to where we are today, robotics seems to play a large market share in that space. I think the clinical utility in the shoulders is coming to a similar parallel manner. We've gotten better with our anchor constructs. We've gotten better with our fixation methods, whether you tie medially or not. The constructs themselves are better. The anchors are better. We've increased our footprint of passage of the sutures and the compression on the medial and lateral row. I think the next step is a biologic step. And I think we're all trying to figure out how to get there. And I think there's pros and cons to all the biologic processes out there. I think you have to find one in the right clinical setting, as we've all kind of talked about today. Can the porosity help you? Can the absorption help you? Can the ability to integrate in at time 0 and then almost resorb to normal tendon tissue over 52 weeks really give you a clinical value add perspective? I think that's where we're going to be at. I think in 10 years from now, I think the cost, which is almost a paramount issue with all these biologics, will start to mitigate down a touch as it becomes more common practice in the clinical setting.
Great answer as always. It's 9 o'clock. Professor Kirschenbaum, I hand it back to you. Thanks for the privilege. Joey's the best platform for this type of discussion. We appreciate it. Thanks again for the invite.
Unmute. I'd like to say that this was the most difficult moderating that I have done. Trying to keep quiet for an hour is very difficult for someone like me. I want to thank our advertiser sponsor, Zimmer Biomet, for helping make this happen. The panel, phenomenal. The open mic part, Nick Scagloni, Michael Redler, and other people who have chipped in, really phenomenal. And Anand, a beautiful job. I think this is going to be important. Recording, we'll have this ready probably by tomorrow on the Joey site and on our YouTube site. And many more people will get to learn a lot of what we talked tonight. So I want to thank all of you very much for an amazing evening.